Welcome everybody to Optometric Education Consultants National Webinar Series, Sunday morning edition. We're very fortunate to hear a lecture on Life Without Blebs by Dr. Anita Brown. She's a board certified ophthalmologist with specialty areas in glaucoma and cataract surgery. Before joining the team at Thomas Eye Group in the Atlanta area, Dr. Brown completed a 2-year glaucoma fellowship at Duke University. Prior to that, she completed a residency in ophthalmology at Howard University after serving an internship at Santa Clara Valley Medical Center. She earned a Bachelor of Science degree in math at Spelman College and a Bachelor of Science in Electrical Engineering at Georgia Tech. Her medical doctorate is from Duke University, where she earned a Doctorate of Philosophy in Biomedical Engineering. And she is a member of the American Academy of Ophthalmology. So with that, please give a nice virtual warm welcome to Dr. Anita Brown as she discusses her experience and a life without blebs. Please take it away.
Good morning, everyone. Thank you for joining me. I'm really excited about talking about glaucoma. If you have any questions, please put them in the chat and hopefully we'll be able to address everything. I have no financial disclosures. I am an ophthalmologist with the Thomas Eye Group here in Atlanta. I have office in Noonan, Georgia, which is south of the airport, and also in Hillendale, which is right off Panola Road out in Decatur. I do want to put a little plug in for Thomas Eye. We are actively recruiting optometrists, specifically people who have interest in pediatric optometry. So here's an overview of what I'm going to discuss today. First, we're going to talk about a patient, and then we're going to talk a little bit about the medical legal liability surrounding glaucoma, and then lastly, all the different wonderful treatment options in glaucoma, because glaucoma is hot. All right. So first, I have a patient. He's a 71-year-old African-American male who presented for his diabetes exam. He has a history of glaucoma since 2013, and he's myopic. He's had diabetes for 10 years and also suffers from hypertension. His history of steroid use, he's also a truck driver, but he's a non-smoker and social drinker. His mother has glaucoma and she's on eye drops. And he also takes a variety of medications for his high blood pressure and diabetes. He was put on latanoprost previously, but had stopped using the drop due to his lifestyle. So if you could launch the poll. So when it comes to primary opening of glaucoma, there are a lot of different risk factors. And I really want this to be a central kind of theme to when you see a patient identifying their risk factors. So what are the risk factors for primary open glaucoma? The fact that he's African-American, his age, the fact that he's myopic, that he has a family history of glaucoma, or all of the above.
And Doc, I'm not sure if you can see it on your end, but the participants are responding nicely here. I'll share the results here shortly. We're getting there. All right,
doing well.
I'm going to end the poll right now and share the results.
So definitely all the above. Kind of breaking down these different risk factors, African Americans are 3 to 4 times more likely to have primary opening glaucoma. Your risk of glaucoma goes up after 40. Myopia is a risk factor for glaucoma. We believe that is because of the anatomy of the eye. When you have such a long eye, the nerve fiber layer is thinner. So if you introduce elevated pressure, there's more likelihood that you'll have loss of the remaining nerve fiber layer that you have. Family history is important. You're 9 to 10 times more likely to have glaucoma if you have a first-degree relative, brother, sister, parent, or children with glaucoma. And 94% of you, all of the above. That's excellent.
Hey,
right.
Doc, I'm going to take host privilege here and just ask the question is, when it comes to myopia, and you mentioned the longer eye, obviously I don't think, Plano or minus a quarter, where do you start? This person is this amount of myopia. I'm going to kind of introduce that as being a risk factor.
I would say someone who has a high myopia, so -6 or above, definitely anyone with any degenerative myopia where they're
Right.
developing, all of the peripapular atrophy, that's a risk factor for for glaucoma.
Mhm.
So all of those things where it's just an abnormal eye, right? The other thing is if there's some asymmetry to the eye. So if you have a patient, they're, like a -9 in one eye, and the other eye is plano, that makes you worry about the possibility of them developing glaucoma in that eye.
Perfect. Thank you.
So on exam, he's 20/40, 2025. His pressure is 17 and 15. He has a thin pachymetry of 452 and 434. His visual field on confrontation is full. He has no APD, normal extraocular motility. On exam, he does have 2+ nuclear sclerosis, cataract, but when we do his gonio, he's open to the trabecular meshwork and has some iris processes. So it's very important to do gonioscopy when examining these patients. Here's just an example of the angle structures. I like to work from the iris out. So if I don't see the pigmented trabecular meshwork, that worries me. You start thinking about narrow angles or chronic angle closure glaucoma. You also don't want to see any obstruction to the angle with PAS or any other, sometimes people will have foreign bodies. They have a history of metal work. So it's really important to see what's going on in the angle when you first examine a glaucoma patient. So what would you do next? If you could throw up the poll. So we already have, a couple of the different risk factors for glaucoma. Definitely, we want to look at the central corneal thickness, which we did in him. It was very thin. So for my patients, I usually use the analogy of if your eye is shaped like a basketball versus a balloon. When you have a very thin cornea, it's more like a balloon versus a basketball. So if I increase the pressure in a basketball, it keeps its shape. But if I increase the pressure in a balloon, which is really thin, it pops, it gets damaged. So that's the best way to kind of remember thin cornea, more likelihood to have damage. So out of these, you can go ahead and do your poll. The different risk factors on exam that you would find.
Okay, I
All
think we're getting
right.
some good numbers.
You see my theme here, all of the above. So definitely, like we talked about earlier, central corneal thickness, the degree of cupping. So my cutoff is about a 0.6 cup. That's when I start thinking about patients being a glaucoma suspect. Also, like we talked about a little earlier, any asymmetry. Usually you can find asymmetry for patients who are chronically sleeping on one side. They can have increased pressure on that side and more damage, or people who've had trauma. So whenever I'm examining a patient, I'm always looking for scars, if they've ever had any nasal surgery, any history of orbital fractures or anything that would indicate the reason for the asymmetry. And of course, elevated pressure. I would say about 50% of patients, even though they don't have elevated pressure, do go on to develop normal tension or low tension glaucoma. But it is something to look for. So what are we gonna do next? I think we have another poll. And the first is to do a 24-2 visual field. I usually do 24-2. There is a lot of data around doing 10-2 for glaucoma patients to pick up earlier paracentral loss. I think a 30-2 is not really useful for glaucoma patients. There's a lot of discussion of whether or not you should be doing it for neuro patients, but I think the data that you get from a 24-2 is perfectly satisfactory. The OCT of the nerve is important. Also, newer technology exists where we can do thickness measurements of the ganglion cell interplexiform layer. So that's kind of the top layer of the macula. And then of course, fundus photos. So we got our results. So again, all the above. I think it's important to take disc photos because as the technology starts to change, and say, for example, you have these disc photos, that knowledge, if you've had a disc hemorrhage before and you have the pictures of that, will help you in the future to kind of follow the nerve, because a lot of the early changes may be picked up if you're able to look at the old disc photos. All right, so for this patient, these are his disc photos in the right eye from 2013 and 2016, and then the left eye from 2013 and 2016. And you can see on the right, there's significant cupping. There's asymmetry in this patient. So the right has more cupping than the left. And I would consider on the right side that to be a notch. So you can see the difference between the superior and inferior part of the nerve. And that is a big red flag when it comes to glaucoma. The other thing that happened during this time is he had a posterior vitreous detachment. And this is important. We'll talk a little bit about the importance of the posterior vitreous detachment. Again, comparing his imaging from 2013 to 2016, you can see that he has some nerve fiber loss in the right eye. The issue though, is that one of these tests was taken with the Stratus versus the Sears machine. And when you have this older type of imaging, you're trying to compare it to the newer imaging, you really cannot compare the thickness numbers. You can compare the maps, but the thickness numbers are not the same. So the reason for this is because of the way that the thickness is measured. So on the left here, we have a picture of a nerve, and then we have the way that the different instruments decide what the thickness of the nerve tissue is. So the yellow indicates the edge of Brooks membrane and what we consider to be the disc margin. The red is the edge of the RPE, okay? So when the Heidelberg, which is like, our gold standard, it's able to actually identify the edge of the RPE and the edge of Brooks membrane to be able to give you really where the nerve starts. The Stratus, on the other hand, just takes an arbitrary measurement from the top of the retina fiber layer to 150 micrometers below that. And that's what it considers the thickness of the nerve tissue. So it's actually a created number as opposed to a standardized number. And then finally, when we talk about the Cirrus, it actually takes a map and is able to calculate the thickness of the nerve tissue. So that's why these numbers can't be compared. So even though you may see a significant drop in the thickness, you have to understand that the Stratus is a calculated measurement versus the Cirrus is actual volumetric. measurement. The other thing that's important, I mentioned a little earlier, is the fact that he developed PVD. It's important because the vitreous can actually pull on the retina and create an artificial thickening to the nerve fiber layer. And so some patients will look like they have a very thick, healthy nerve fiber layer, but it's really because that vitreous is pulling on the nerve fiber layer. And you can see a dramatic change in the nerve fiber layer thickness once that vitreous has attached. So you would think that the patient is progressing significantly because of the measurement that you take before the PVD and after, if that makes sense. These are his visual fields from 2013. On the right side, maybe some inferior change. Left side, maybe some paracentral depression. But again, the reliability on that left side is not as good. Usually patients get tired if you have any experience with visual fields. And the left eye can usually be a lot worse. They have a tendency to have increased fixation loss, which is what happened here with him. He does also have some generalized depression, likely due to his cataract. And as you can see, it got worse. On the right side, we have what looks to be an inferior arcuate. On the left side, some inferior nasal depression. The thing to kind of worry about on the right side is that it may be a clover link, so he might not have actually been awake while he was doing this test. So we definitely want to repeat anytime you see a significant change in the visual field. Sometimes it's good to bring the patient back and just do one eye at a time. But that's an early sign of a clover link, which indicates that he might not have been attentive throughout the whole test. But definitely some changes in the visual field over those couple of years. So now I'm going to transition a little bit into the medical legal side of glaucoma. The biggest problem is the failure to diagnose or a delay in diagnosis. So that's why I'm spending so much time talking about the risk factors and the testing that is extremely important for patients when you worry about glaucoma. As you can see, there are a lot of different claims going from improper treatment, failure to monitor patients, and we have to be vigilant in trying to detect these patients and then treat. So of course, in treating patients, what I see a lot is under treatment. So for example, we have the AGES study, which tells us that the goal is to keep patients under 18 at every visit. If they do have mild glaucoma, you want to keep them under 18. If they have moderate glaucoma and they're starting to develop visual field deficit, you want to keep the patients under 15. And in advanced glaucoma, the goal is to keep them under 12 to make sure that there's no progression. Definitely, we have difficulty, especially during COVID, of monitoring patients. At Thomas I, it got so bad that we were checking pressures in the parking lot just to be able to keep track of people. And I'm a proponent of, if somebody calls and they need their medications, I reorder their medication at least a month's worth in order for them to have the medications and be able to see me, be able to get into the clinic. This goes into record keeping and being able to document all the different kind of proponents of the medical record. You definitely want to document the pressure. You want to document the nerve. We have some great imaging tools now so that you don't have to dilate people at every visit and taking fundus photos. It's important to document any non-compliance. So if you have a patient that's not using their medication or using their medication improperly, or not refilling their medication. It's important to document all of that and their missed appointments. The number one reason people get sued in glaucoma is due to steroid-induced glaucoma. So you have to be careful when you're putting people on steroids for allergies or dry eye, and making sure that it's only for short-term use, or using some of these steroids that are not as IOP increasing, so switching more to like a Lotamax or Flarex, and trying not to use them more than 2 weeks.
Anita, just to share with you, one of the final cases before I moved out of academia was a 21-year-old woman who had steroid-induced glaucoma, pressure bilaterally 72, because she was self-medicating her asthma with injectable dexamethasone 3 times a week that she imported from Honduras.
Yeah, dexamethasone, Durezol, that's the bane of my existence. It is really, it's really difficult, because when patients go on steroids, the steroids can change the trabecular meshwork permanently. So even when you get them off the steroids, they still have decreased outflow through the trabecular meshwork. And so it's important not to kind of let these patients, and this is all kinds of steroids, everything from creams to inhalers. I've had patients come in getting, shoulder or knee injections, cortisol injections in their back and neck, and it definitely worsens their glaucoma. And if you're worried about them, the best thing to do is to have them come in about 2 weeks after they've started a new medication or nasal spray, and see if it's actually causing the eye pressure to go up. Again, here's just a list of different reasons people get sued. I'm so glad glaucoma is not number one, but definitely cataract and retinal detachments that are missed. I had a patient come in this week for a diabetes exam and had a huge retinal detachment and was completely unaware. So it's always important to do dilated exams on patients, or at least get really good imaging to be able to see the peripheral retina. So now we're going to move into treatment options for patients. We're going to start with medical therapy, and then talk a little bit about laser treatment, and then incisional surgery, excuse me. So there are some new medical treatments out there. Tarcidal is one of the newer medications that was most recently developed. It's a Rho kinase or ROCK inhibitor. And how it works, unlike any other glaucoma medication that we were able to use before, is it increases trabecular meshwork outflow and can actually decrease episcleral pressure. So one of the side effects, though, when you start a patient on this drop, is that their eyes can be severely red. They can have subconjunctival hemorrhage. Usually, if they stay on the medication, it improves over about 2 to 3 months. So before I start any patient on this medication, I give them that warning, kind of like you would with the prostaglandin analog. Just warn them that their eyes are going to be significantly red. I have not been using this as a first line medication due to the difficulties with insurance. I usually use it as I'm preparing someone for surgery, or in patients that are not tolerant of the other medications. I will try them on this drop. Some of my colleagues are definitely using it as first line, especially if folks are failing the prostaglandin analogs, because it's still a single-use medication in combination, the Tarcidal with the latanoprost. And so sometimes that can help with compliance. We also have a newer medication. It's a latanoprost with a nitrous oxide kind of added to it. And so it helps with increasing uveal scleral outflow because of the prostaglandin analog. And then the nitrous oxide actually is a vasodilator. And so Schlemm's canal and the trabecular meshwork is actually smooth muscle tissue. So it dilates, kind of like why people take nitrous oxide, sublingually when they're having chest pain, because it will dilate the blood vessels around the heart to help flow. It was compared to timolol daily and was shown to be non-inferior. And then it was also compared to latanoprost, and they haven't shown that big of a difference between the latanoprost and the LBN, but I found in my practice that it's the same kind of move where you want to see if a patient is, on maximum therapy, if you can get a little bit more help by adding one of these newer medications. But definitely there are a lot of challenges surrounding getting the insurance to approve these changes. So I usually use it sort of further down in my treatment regimen. But there are other glaucoma docs and comprehensive ophthalmologists who will use this as first line because of the compliance issue of changing from a single-use medication to, twice a day or 3-time medication.
Doctor,
Doc,
you
go ahead, Joe.
mentioned how there's a 1 millimeter difference from latanoprost to latanoprost bunod. I think it's also important to acknowledge that we talk about the super responders, people who do actually a lot better. And I know I am one of those super responders. I've got glaucoma, ironically enough. I probably caught it from a patient. But for me, latanoprostine bunod alone gives me almost the same pressure reduction as Combigan and Lumigan together. And my peak pressure was 42.
Yeah, I think that is one of the things that we're learning from all of the new medications that are out there, is that the mechanism, the personal kind of results vary. Like you can get a patient who does not respond to latanoprost, and you can put them on, Vyzulta or Rocklatan, or even on, a different brand of prostaglandin analog, and they'll have a much more significant response. So I think that kind of goes into personalized medicine. I think that's going to be the future, is trying to identify who is better treated with different medications. I think that's kind of what's happening in cardiology. We know that certain medications work better in certain populations. And so trying to, collect data to identify who's going to do better with different medications is extremely important. And it's the future of medicine.
It would be great if we could identify who would be a super responder. We just don't know that. And I'm just saying that because I want to head off maybe a future question from our audience. But ironically enough, we, individual or personalized or tailored medicine, we can go through all these characteristics, and still at the end of the day, we have to prescribe what the insurance will pay for.
Yeah, it's definitely challenging. And I think, if we can have data to kind of support our decisions in prescribing, I think that it makes it a lot easier to make the case. So there's a pull to standardized medicine. There's a pull to private, to personalized medicine. And there's also a pull for equity. As the National Medical Association president of the ophthalmology section, one of our tenets is for equity. And so if people aren't able to have access to these different medications because of, their health insurance, we are creating disparities in health. And we have to be careful with that. And we have to be very vigilant to kind of stop that from our practice patterns.
My only comment was going to be with regarding the Tarcidal, there's a real quick clinical pearl out there is it's really, really good at lowering a low IOP. So it typically lowers about 4 or 5 millimeters. Whether it's a 25, it takes it to 20, or a 28 down to 23. Sometimes you do get a little bit of a super responder, but we all know how hard it is to lower a 16. And it just seems to work. 16 will go to an 11. So if you're looking for that drop that's going to help lower a low IOP, look at that in the Tarcidal product. That would be my comment.
Yeah, I agree. It works really well in normal tension glaucoma and low tension glaucoma. There's a lot of research out of Japan where they have a lot of low tension glaucoma patients, and it's a great medication. It was actually developed at Duke while I was a fellow there and medical student. It took years for our chairman to kind of toot the horn of us trying to find something to treat the trabecular meshwork, because most of the glaucoma medicines will kind of turn down the faucet, right? So decrease production. And we worry a little bit about that because there is an importance in production of kind of clearing out the aqueous. And so when you're using beta blockers and carbonic anhydrase inhibitors, you're actually decreasing production. And we have to be careful with that, because I think the natural kind of functioning of the eye is to have the aqueous constantly being turned over.
Here's a question that came through our chat from one of the attendees. And aside from diurnal variations, what are other causes of fluctuation in pressure in a patient with open angle glaucoma?
So there's definitely,
I'm sorry, it just came through. They continue the question. Maybe not a glaucoma patient specifically, but maybe a glaucoma suspect as well.
So definitely in terms of, we have these new contact lenses that are able to measure pressure, throughout the day. So different postural changes. So when people are laying down versus standing up, we always talk about the yoga positions where you have increased eye pressure, downward dog, and all of these different things. But definitely there are postural kind of changes that can fluctuate eye pressure. And fluctuation in eye pressure in general is a risk factor for glaucoma. So if you have a patient that you see and their pressure is varying, more than 5 millimeters of mercury when you're seeing them, that's actually a risk factor for glaucoma. In terms of like dietary changes or, altitude or anything like that, there's a lot of anecdotal information. I mean, I know they're doing a lot of research on astronauts and the optic nerve and how it's affected by zero gravity. I mean, there's a lot of research around how these things affect the optic nerve and brain.
The only other things I could think of besides inversion, as you had mentioned, maybe some chemical ingestion. Alcohol can lead to dehydration and lowering pressures. And I learned that when I was teaching in optometry school, tonometry in the lab the day after St. Patrick's Day. We had a lot of single digit ILPs with people whose students were hungover, and maybe even the more increasing use of medical marijuana.
Yes. So the issue, my patients ask me about medical marijuana all the time. And the issue, what I usually say to them is, yes, marijuana will lower your eye pressure. The effect is usually about 2 to 3 hours. We have medications that last 24 hours. So I would choose those medications over prescribing medical marijuana. But I do think that the future will include some type of medication. The issue is that, the eye is an extension of the brain. So it really is difficult drug delivery when we start talking about THC and larger molecules being able to cross that barrier through the cornea. And so I just tell my patients, you know, you're going to have to be smoking all day and all night to,
Yeah,
to
the
be able to
phrase,
keep
yeah,
your eye
the phrase I
pressure.
use, the phrase I tell my patients is you have to achieve a Cheech and Chong level. And about half the patients understand that reference.
Yes. And some of them, you know, they're like, and so I can do that, Dr. Brown. I was like, no, I'm not a big fan of medical marijuana. Um,
Hey, Doc, I know we're kind of getting off topic here, but what about the CBD side? Isn't there research out there that the CBD, which when you take out the good part of the marijuana, the CBD, which doesn't give you the high, the emotional part, the psychedelic part, doesn't that cause IOP to go up maybe about 40 milligrams? I think I've seen. Have we seen that?
I'll be perfectly honest. I'm not really
Okay.
sure about that.
Right.
I
So,
just don't really know much about medical marijuana. I think that there's a lot of research because you know the whole field is shifting, and they've been using it for a lot of different things. I mean, we go through these kind of phases of different medications and different things that people try. But like I said, it goes back to that kind of divide of personalized medicine and, you know, standardized medicine, and trying to figure out who will be the best treated with different medications.
perfect. Well, we've hijacked you enough. We'll let you go on.
It's okay. Um, so in terms of other medical treatments, we have a bimatoprost ring, we have injectable travoprost, and a newer device that will be on the market is the glycose iDose, which is an implantable device that can be reloaded. Most people know about the bimatoprost sustained release device. In trials, it was found to be effective out at 3 months. So I usually tell patients it's the rule of threes. So about a third of patients with just one injection were able to maintain this 30% reduction in IOP. And then with second injection, about a third of them were able to maintain a low IOP. And then with the third injection, another 1/3 of those patients were able to keep their eye pressure down. One of the adverse events was hyperemia, just like you would find with traditional eye drops, traditional bimatoprost. This is a picture of a patient that I did an injection in. He did really well for the first 3 months, but after that, I was kind of stuck looking at this injection because it stays around. It can stay around for 6 months to a year. And sometimes it will, like, there will be like a fibrin kind of around it or pigment around it, even though it's not working anymore. But it does disappear over time. We are not yet at the point where we can do multiple injections. Hopefully, you know, first of the year, we'll have more data out from the FDA about doing multiple injections. So the glaucoma docs are not yet retina specialists. We can't have them come back every 3 months to do injections. And also first line treatment, we talk a little bit about SLT and ALT. ALT has kind of gone out of favor. I think there are still some docs that are doing ALT. The issue with ALT is that it can scar the trabecular meshwork and cause permanent damage, versus SLT is repeatable. Usually I wait at least 2 years before trying to repeat an SLT. And then some patients, they have very good response to SLT and can, you know, not have to use drops. I always tell them, you know, if I had glaucoma, I would choose an SLT over medication because of a lot of the side effects of these medications. We have some new lasers that are coming out or have been kind of used There's a micropulse laser that also, so instead of an SLT is a, you're giving the same amount of laser at every shot versus the micropulse, you're giving multiple short impulses. So the tissue doesn't heat up as much and doesn't cause as much permanent damage. The idea is to stimulate the pigmented melanocytes in the trabecular meshwork by the wavelength of light that you're using to try to clean up the trabecular meshwork. So you're stimulating those cells to start cleaning up the trabecular meshwork so that there's greater outflow. Usually results in about 20 to 30% IOP reduction. And there's less likely collateral damage with the SLT. It's not painful. I tell my patients the worst part is the lens that we have to put on your eye in order to see the trabecular meshwork. And so, the gonial saw can be kind of annoying for them, but they're less likely to have IOP spikes and usually will have a better baseline pressure. So even if they are non-compliant, the pressure doesn't go as high when they're not using their medications. So this is how I feel about Blebs. Not really excited about Blebs. And the reason I'm not really excited about Blebs is, the list goes on and on, but the idea is that we're taking this aqueous fluid and instead of it going out of the normal Schlemm's canal outflow and being collected by the episcleral vessels, we're trying to reroute this outflow. And so we've gotten really good at trying to do surgery in the actual angle so that then the fluid can continue to go out of the eye through a more natural pathway as opposed to creating a whole different route for the fluid to exit the eye. This is a electromicrogram of the outflow in the eye. And the thing that's important to see is that we're working in a very, very small space when we start doing trabecular meshwork surgery. And we found that patients who have glaucoma, there are aging factors that are starting to present in the trabecular meshwork. There is cell death, apoptosis. All of these things are going on in the trabecular meshwork. So the idea of stenting or removing the meshwork is kind of our new first line treatment and therapy to help outflow. So the goal would be to be able to get the fluid from the anterior segment either into the suprachoroidal space or into Schlemm's canal directly so that then you have a more natural outflow. So I think I have a polling question. So trabeculectomy with mitomycin C is the gold standard surgical treatment for primary opening glaucoma. True or false?
I can tell you one thing, Doc, that I have a lot of experience, at least back about 10 or 15 years ago with these blebs and trabs and doing the post-op care and pressures of 0 and trying to manage choroidals and valves that are leaking and when mitomycin. So you might not like them as a surgeon. I certainly didn't like to do them as post-op care. So
no, it is not fun to manage a bleb. It is definitely not fun.
Massage and pulling stitches and now you can laser them. Yeah. So luckily there's some newer things that are out there. So
it's a lot of art and a lot less science.
It definitely became an art. So yeah.
No, I think we probably have the results from the poll. So the answer is actually true. It is still the gold standard for glaucoma care. We have not yet shifted that. We're not yet to the point where MIGS would be the gold standard for care. But trabeculectomy is where you make a flap in the side of the eye. These flaps are mid-thickness, and then you make a hole into the anterior chamber of the eye and create a bleb. Comparable results are found when you, instead of actually making a hole, you use a stent. So we have like the express stent. And then there are also tube shunts. There's an Ahmed that has a valve. There's a newer Ahmed with no valve. The Baravelt has no valve. And there's also the Zen, which creates a bleb. So again, all of the complications of a bleb, you can get hypotony because of overfiltration. You can get a blebitis and actually see a hypopion in the bleb. And that's an ocular emergency because it can end in endophthalmitis. So you have to be very aggressive in treating blebitis. You can also get synechiae. So when you're, making this hole, you can actually, the iris can plug and close the trabeculectomy. You've probably seen encapsulation, the patients that have this huge scarred bleb that just is irritating, chronically irritating. The thing that I don't even want to say it, knock on wood, is a choroidal hemorrhage. So if the pressure is too low, and the patient will wake up with pain, vision loss, and what happens is when the pressure is too low, the choroidal vessels can hemorrhage, and the visual outcome, even after draining those hemorrhages, is very poor. So the rapid decrease in pressure in a patient having any of these type of surgeries can also put them at risk for choroidal hemorrhage. And of course, we have failure and bleb dyskinesia. But this is just the short list of all the different problems. Here's a picture of a bleb leak. If you ever see a bleb, you always want to check to make sure there's no bleb leak. Similar to checking a cataract patient post-op day 1 and make sure that they're Sidel negative. So the new kids on the block, we have a lot of new glaucoma devices, and this list is constantly changing. I think my handout is actually even old now. So, take a screenshot. I think it's going to continue to change. Every year I go to the Glaucoma 360 meeting out in San Francisco, and I learn about all these new and exciting devices that are coming out in glaucoma. So we're definitely pushing the limits to what we can do. Specifically focusing on the meshwork. The iStent is still available. So there are some comprehensive docs that really like the iStent because you can create a little bit of a goniotomy before placing the stent. iStent inject right now, they only have 2 in the system, but in the future they're going to have multiple injections, so you can put in like 3 or 4 in iStent injects. The Hydrus is a newer device. It's an actual stent, and it takes up about 5 clock hours of the eye. Other devices that are not implants, other surgeries that we do, of course, is the Cahook. And then that is when we actually remove the trabecular meshwork, versus gap procedures. And the eye track is when we're just opening it as opposed to removing it. The Omni is a very exciting device because we can do viscodilation and canaloplasty. So we can actually dilate Schlimm's canal. And then if you want, you can also remove it. Lastly is the trabectome, which was actually a cautery device where you remove and cauterize the trabecular meshwork. This has gone out of use because long-term data has shown that that damage actually can result in pressure going up over time. Newer devices in the suprachoroidal space include the iStent, Supra, which is a device similar to the mini inject. It's just made out of a different material, and those actually make the fluid go into the suprachoroidal space. They're a little riskier, as we've seen with, the results from the CyPass and that being taken off the market. There is loss in endothelial cells over time. I think that, the CyPass was a great device. I think these are great devices. And the difference is that when we first started doing tubes, we weren't really measuring the amount of endothelial cells or endothelial loss. But now with newer devices, that is one of the asks from the FDA. And so tubes have always been doing this, trabs have always been doing this, but these newer devices, we are actually getting the numbers around it. And so a lot of the pushback is because of loss of endothelial cells.
Doctor, do you think that the negativity against the CyPass is legitimate, or is it kind of overblown? I know a lot of surgeons who, before it came off the market, did very well with it. I think, people were being told, well, if you push it in too far, it's not going to work. So leave it out a little further so it works better. And those are the ones that seem to have the endothelial cell count loss. So what are your thoughts there? Was this real? Was it pulled off prematurely, or was it really a hazardous device?
I think that it all came down to training and how they brought it to market. So they brought it to market similar to the iStent and made people think that it was, a very minimally invasive type of device, and that comprehensive doctors could use it, and that there weren't a lot of, of bad outcomes or things that could go wrong. And so I think if the new phase of introducing new devices is to start with glaucoma specialists as opposed to comprehensive, and then have it kind of transfer into comprehensive doctors. I think that the CyPass was a great device, and I think that if you place it properly, it works really well in a lot of patients. So I think it was kind of the way they marketed it, and like learner error, so if you're not teaching people how to place it and what to look for, a lot of times, these patients were suffering from endothelial cell loss. I see patients that have had CyPass and they're doing fine. I used to use it specifically in older patients that I didn't want to do trabs on because of the follow-up and the maintenance associated with trabs and all of the different risk factors, people who are on blood thinners and, are in nursing homes and all of these different things that make it hard for them to come back and me to manage that bleb. So I think it was just learner error and kind of bringing it out to the wrong crew of surgeons.
Yeah, I think it's important to emphasize, these are minimally invasive, but they are skilled procedures that people really have to learn how to do and to do well. There's no free lunch here. I remember Greg and I were at a major conference, and we had a chance to do a hands-on, I think, with the Zen. And Greg did a pretty good job, and I think my mannequin got endophthalmitis.
Yeah, I think angle surgery is definitely something that not everybody can do, and I think that you have to be taught, and you have to be taught well. And it's not even the actual surgery; like it's actually dealing with the post-operative care. And I think that's where, we collaborate a lot with optometrists and trying to identify problems early and things that can be fixed earlier. But I always tell my patients surgery begets surgery, right? So once you start heading down the line of doing surgeries on people, you have to be prepared to do more surgery. You have to be prepared to put in tubes and do trabs if things don't go as planned.
Before we move on any further, there was a question that came into our chat room a little bit earlier. Because you're mentioning low tension or normal tension glaucoma. The question is, what's the best treatment for a low tension glaucoma? What's first and second line in your opinion?
Well, I think for low tension glaucoma, you have to make sure that it's a diagnosis of exclusion, right? So you have to do a full neurologic workup, make sure that they don't have any vitamin deficiencies or any other causes of nerve damage. So if there's any pallor to the nerve, if there are any other underlying conditions, I have a neuro-ophthalmologist that I work with because I see so many nerves. So I usually will run a low tension glaucoma patient by a neuro-ophthalmologist. You get, it's just like migraines. You get one free MRI, if you have a new onset of migraines or a low tension glaucoma. In terms of treatment, I think, the Sittish study kind of showed us how to treat low tension glaucoma. We want at least a 30% reduction. So I think it's the same paradigm as primary opening of glaucoma, is to try to reduce the pressure to decrease progression. These patients, they don't do as well with MIGS, just like patients who have any sort of angle closure or narrow angle. It's very difficult to use any of the MIGS, and in some cases almost contraindicated because you don't have a good view of the angle. So I would start out by trying to reduce the pressure by 30% with our standard medications. I usually use a prostaglandin analog as my first line, and then move to beta blockers and combo drops.
That's funny when you say beta blockers. I'm glad to hear you say that too, because there's this theoretical issue with beta blockers or alpha adrenergic agents to it's going to decrease the perfusion. My answer is whatever works, whatever gets pressure down is what we should do. And we have to try different things. I know the Sidgets told us that their goal was a 30% pressure reduction, but my experience is, or what I tell people is, when you have a patient who is in the normal tense of range, look for 50%. That's when you're really doing something. They start at 20, they should be at 10. They're at 16, they need to be down at 8. You need to try to reach that 50%. 16 down to 13, I'm not really sure we're doing a heck of a lot.
Yeah, I think one of the things that speaks to is the variability in eye pressure, and how when you have a patient in your office, you're just getting one data point. So the better the reduction, the more likely that when they're out doing their other activities, that their pressure is not extremely high. So I think the lower the better. I think as long as you're not experiencing side effects, as long as their lifestyle isn't changed. If you put patients on 5 different medications, all they do all day is put in medication. So they're not able to kind of do what they normally do. So it also is a lifestyle balance.
I think we're caught up on our questions. Thank you.
Lastly, there are lasers that we use to decrease production. Those fall into transscleral cyclophotocoagulation and endoscopic cyclophotocoagulation. So TDC and micropulse, those lasers are done on the surface of the eye versus endoscopic. You actually have a camera and you're able to go in and ablate the ciliary bodies from production. So again, the anatomy of the eye is extremely important when we're trying to remove the trabecular meshwork. The highest resistance is at the juxtacanicular meshwork. So it's not just a surface removal of trabecular meshwork. You really have to get it to bleed. You have to get to the point where you're in Slim's canal and you have some backflow of blood into the anterior chamber. So a lot of times people are like, oh, these medications these surgeries cause bleeding. Well, like that's what we want because that's how we know that we've removed enough of the trabecular meshwork to actually treat. So here's a picture of the iStent inject. The design has changed recently. It has a wider flange to the back. So what was happening is a lot of them were moving actually into the trabecular meshwork. So you would see a patient that you thought you did an inject on and there's no inject because it was actually moving into the trabecular meshwork. So they have a larger back now. They are safe for MRI, and you can, I think it's up to 3 Tesla MRI. It's made out of titanium. I use them usually in patients with mild glaucoma. I don't usually use them in moderate glaucoma. My treatment paradigm is if you're on one medication, you can get an iStent. If you're on more than one medication, then I have to move to a more aggressive treatment. So the trial showed that they improved IOP reduction versus cataract surgery alone. The iStent cannot be done by itself. It has to be in conjunction with cataract surgery. So I have a lot of patients that come in and they've had their cataract surgery and they're like, well, I want to get an iStent, and that's not something that I do. So I will move on to doing angle surgery, goniotomy, or something more advanced. So definitely you get a pressure reduction with cataract surgery by itself. So we don't really know the mechanism. Some of it is anatomy, some of it is the phaco machine, but you're gonna get a pressure reduction with cataract surgery. This pressure reduction though is not long-lived. Usually it only lasts for about 6 months. It's not permanent pressure reduction with cataract surgery. So here's the angle. Again, we're trying to get it into the posterior pigmented trabecular meshwork. I've seen them everywhere. I've seen them in the cornea. I've seen them in the iris. So I think, like we were talking about earlier, you really have to be taught well how to do these surgeries and deal with the complications. And sometimes they fall out. So you can see them in the anterior chamber, just sitting there on the iris. So, any history of iStent, you gotta look at the angle to make sure that they're still in good placement. Sometimes they can be covered by the iris. You can get synechiae. I have not had good results lasering iStents. Some people talk about, doing a YAG to try and open them up, but I haven't found that works very well.
Here's a question that just came in. What's the standard of care for number of iStents placed in one eye? Sometimes I see one, in others I see 2.
So the goal is to try and put them far enough apart so that you're reaching different collecting channels. So previously we thought that Slim canal was just a big loop and it was continuous, but in reality it's segmented. So there are different areas that flow to different blood vessels and have different outflow. So the idea is that you want to try and target multiple areas. So right now, the traditional iStent, the snorkel is just one area, but a lot of the doctors are carrying it to multiple areas, doing a goniotomy and then leaving it. But with the newer iStent inject, you have multiple injections, so you can try and get different collecting channels, excuse me. And so in the future, the iStent inject is going to have more than 2. There's going to be multiple injectors that you can put throughout the angle. Again, adverse events with the iStent. you're going to get a hyphema because that's what you want. That's how you know that you're in the right space. Some patients do develop corneal edema. That's usually because of, some doctors, when they're doing it, they can damage the cornea on their way to the angle if you're not steady. I think a lot of these other post-operative are kind of risks of doing cataract surgery. You can have a loss in vision, you can have a PCO. I talked a little bit about stent obstruction, and you're gonna get a cell, and you can have corneal abrasion sometimes if you're not good with the gonio prism.
Doctor, you mentioned hemorrhage, and we want a little. What is the most hemorrhage that you see after an eye stent? And I'll share with you the case in just a second.
Usually it's a microhyphema. I mean, I usually, when I end the case, I have the patients keep their head above their heart. That's my, standard protocol, even for cataract surgery. And so, usually it clears within a day or two, but if you have, chronic bleeding, if somebody is on a blood thinner, we kind of try to stay away from angle surgery. Usually you can, just tap them, and that usually is enough. Some doctors will leave some of the viscoelastic in the AC to kind of protect from hyphema. I have had to do a washout on some patients that just chronically bleed. Usually those are the diabetics who are just, very fragile when it comes to bleeding, or anybody on chronic steroids, immunosuppressed.
Well, when I was on call in my new practice, we had a patient undergoing cataract surgery and eye stent placement. And I get the call, and he's got an 8-ball hyphema, which is not really typical. But when I saw the patient, and I do the neuro op in our practice, I realized they put an eye stent into an eye that either had or developed a low flow carotid cavernous sinus fistula.
Oh, I'm so sorry.
I never saw the patient preoperatively,
Right up.
whether if that was there or not, or the patient developed it subsequent to the procedure. But I'm looking at the dilated, episcleral vein, and said, "Yeah, this may not have been the one to put the eye stent in." Glug, 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 glug.
Right up. Yeah, that's horrible. Oh my God, that's horrible. Yeah, and there's no way to fix it. Once you've opened that trabecular meshwork, we don't really have anything to. I mean, I guess for hypotony, you could do like an ALT to try and like scar down whatever's left. But yeah, no. That's...
No, I informed the surgeon and the co-managing OD what was going on, and then I tapped out. I'm out. Thank you.
Yeah, no,
I made my diagnosis. We're done.
Yeah, that's very scary. I mean, I think, we probably should do a whole discussion on glaucoma masqueraders. There's a lot of things that look like glaucoma but are not glaucoma. And that's why with the low tension glaucoma, you really need to do a workup. Glaucoma is a diagnosis of exclusion, so everything else has to be kind of taken off the table. The Hydrus microstent is something that I absolutely love, and I highly suggest. I think it is a wonderful, wonderful addition to the glaucoma kind of MIGS panel. Again, it is biocompatible. The patients can have MRI. They're not going to have any issues. The Horizon study showed that it lowered eye pressure. Definitely, you have to do it with cataract surgery. I've found that patients that are on multiple medications can get off of the multiple medications. So unlike the eye stent, that's a 1-for-1. Hydrus is something that you can use in patients that are on multiple medications. It is a scaffold that you place into the trabecular meshwork. it definitely goes in very smoothly, and it's a lot larger than I expected when I first started using it, but it works very, very well, and you will get some bleeding. The other device that I use in patients that are on multiple medications with mild to moderate glaucoma is the Cahook dual blade. As you can see in the picture, there are two blades, and you're more or less scooping out the trabecular meshwork. The biggest issue is that, you know, you're going to get a hyphema because you're opening up the trabecular meshwork, but it definitely is good for IOP reduction, and it can be done as a standalone procedure because it is a goniotomy. Versus the iStent and the hydrus have to be done in conjunction with cataract surgery. And there has been shown to be a decrease in medication use and IOP reduction with this device. The next is the GAT procedure. This device is made, it's called an eye track, more or less. So you place this into Schlimm's canal, and you can actually see it go all the way 360. Sometimes because, like I said before, this Schlimm's canal is segmented. It may be some difficulty implanting, but afterwards you do a trabeculotomy and actually pull the stent and open up the trabecular meshwork. And like all of these procedures, you can develop hyphema. I think we have a question. I mean, polling. Yeah. So true or false, the Zen stent creates a subconjunctival bleb. True or false?
And Doc, as you're going through this polling question here, I think, you know, it's worth saying, I think it's obvious, but sometimes it's worth pointing out the obvious is that glaucoma has now been identified as a trabecular meshwork disease. It's having trouble getting through that trabecular meshwork. It's become oxidized, stiffened. And all of these procedures, even the medications, like you mentioned earlier, the Tarcidal is trying to work on, you know, expanding that trabecular meshwork, the nitric oxide, and now we're using all these procedures here either to bypass like the iStent or the Cahook dual blade, actually kind of carving some out. And so, you know, just kind of worth echoing out there that, you know, is glaucoma a disease of inflow or outflow? I think we've identified that it's an outflow on that trabecular meshwork area. And that's why we've seen recently over these last few years, all these targets, whether it's the side pass that was recalled or, you know, the procedures that we're talking about now, you know, trying to bypass that disease trabecular meshwork.
Yeah, I think, you know, we know that glaucoma is a disease of aging. And so these cells that are in trabecular are no longer functioning. They have all kinds of factors that, you know, when we do the Cahook, we actually collect that tissue and are able to do research on the different factors that are presented in patients that have glaucoma versus, you know, normal patients. And there's a lot more scarring. There's a lot more pathology in patients that have glaucoma, the trabecular meshwork. If there was some way to revitalize it, you know, it's like the serum, you know, to stop aging. And I think across the board, you know, I think that's the future, is trying to figure out how to stop cells from aging prematurely.
And I know you mentioned earlier about, you know, normal tension glaucoma and vitamin deficiencies and needing that workup and that neuro. And I know that's passion to Joe, and Joe has made it passionate for me, this neuro side of it. But even there's a nutritional side to it, I believe, because, you know, Joe kind of joked, he thought he caught it from a patient. But I can tell you, 25 years being in practice, I'm starting to now see patients coming in that are husband and wife having, you know, ocular hypertension or glaucoma they're not genetically related. So there's something I think going to be unfold at some point as some nutritional component to it, because they're probably eating the same foods and so on and so forth. So it's going to kind of be neat, as you said, to kind of see this, how this unravels as we go down this pathway.
Yeah, I mean, there's a really good book. It's called The Plant Paradox. And he talks a lot about stopping aging by your diet and changes in your diet, and a lot of things that people do and eat that actually causes inflammation and aging. So I think medicine, like when I was in medical school, I'm like aging myself now. When I was in medical school, we didn't really talk about diet outside of, diabetes treatment. But now, there are a lot of good data surrounding anti-inflammatory diets and kind of changing your fuel. And it makes complete sense that you are what you eat, and
Yep.
so patients that have things that run in their families, it's not really the family DNA, it's more the customs and the different patterns of behavior that cause disease. So I think there's a lot of new information and really good data around diet and exercise and sleep. And I think with COVID, there's just like this whole outflow of information about how people are, responding to different treatments and how to kind of keep yourself healthy.
Yeah, it's the kind of the same thing I just heard someone say the other day about, pick your parents wisely is what we used to say, but really only 8% of what we get from our parents can't really be changed. It's the other 92% of what we're doing to our bodies is now the epigenetic side of it. So yeah, it's going to be really neat to see what happens. And I think it's going to apply to glaucoma too. So it's going to be neat to see what happens as this unfolds.
Yeah, I agree. And I think, when we start talking about health disparities, we have a lot of risk factors that have absolutely nothing to do with our standard thought pattern of risk factors. There are a lot of social determinants of health, whether one of your parents was ever in jail, whether or not you ever missed school as a child. Like there's all these indicators of health. And so, I'm becoming a social worker, like it's evolving, because you realize that if you don't treat the whole person, you're not really going to be able to help them in their disease process.
Very well said. Yeah.
So let's go back to the poll. The answer is actually true. So, Zen is when we start crossing the line. This is where we're starting to deal with Blebs again. So the surgeries are moving into placing a stent, as opposed to with the traditional trabeculectomy, you have to create a flap and you're entering the eye with a hole. This is actually a stent that's placed subconjunctivally from the anterior chamber into the suprachoroidal space, and then into the subconjunctival space. The issue with the Zen is that these Blebs scar. So I don't use this surgery in African-American patients because they scar rapidly. And there is a group of folks that do mitomycin with this procedure. And so they will kind of treat it like a trab. They'll treat with mitomycin before, and have found some good results. But in my patient population, they don't work as well because of the scarring that I see with any bleb. So I do more tube surgery when I start thinking about creating a bleb.
So help me out with the anatomy here. There's the subtenons capsule was in there. Are we going through subtenons and staying below the conjunctiva? Obviously, we don't want to go through the conjunctiva. Or are we conjunctival and subtenons, or does that matter in any way where the tenons is?
Yes, definitely want to be above the tenons.
Right.
Do not want to be under the tenons.
Right.
Do not go under the tenons. Stay away from the tenons. Yeah, that will block if you run it into the tenons. So when you give the mitomycin and you blow up the conj, the whole goal is to be able to separate where you're coming out and make sure that it's above the tenons. And some, like I said, some docs are actually opening up the conj like they would a trab and removing tenons to make sure that it doesn't block the Zen. So there's an ab internal and an ab external approach. And so a lot more of them are doing the ab external approach to make sure that they avoid tenons.
Perfect. Thank you. I knew the tenons was important. That's why I wanted you to be able to speak to it. Thank you.
And there's a lot of needling with these. So it's a lot of chair time to make sure that it's flowing. And sometimes they're yagging them, if they get blocked. So it's kind of like I would equate it to like spaghetti. That's kind of the thickness and feel of the Zen. Moving on to the lasers. So traditionally we did TDC laser. There's also more research out about TDC laser. So originally, you laser, you're trying to completely annihilate the ciliary body just to decrease production. But what we found is that it can cause you to have a lot of inflammation. So we're kind of playing with the settings of TDC. So there's a low setting TDC. So that's a lot of the work of glaucoma specialists is trying to kind of pull back the destruction and more trying to just treat the tissue so that it doesn't make as much fluid as opposed to destroying it and causing inflammation. And so that's where the micropulse comes into play. You can see at the bottom, TDC is continuous laser treatment versus a micropulse. It's multiple pulses of heating and cooling and heating and cooling. And so rather than a continuous burn, you're getting heating and cooling of the cells. And so there's not as much damage. Micropulse is kind of going out of favor. They tried to change the probe to see if they could get more reliable treatment, but the treatment is so variable. Originally, it was based on the vision of the patient and trying to get into a sweet spot of laser delivery. And so it's, I'm not doing as much micropulse because you don't get the response that you can predict, and so micropulse is kind of going out of favor, but it does use the same laser system. So if somebody's doing micropulse, they can still do TDC. It's just a different probe. And again, trabectome was like the first generation of angle surgery, and it worked really well. And then as time went by, we started seeing that the scarring and actual ablating of the angle was problematic. And we kind of have gone out of favor. So I believe most people's trabectome kind of sits in the corner and holds their jacket when they do surgery. So not as many people are doing trabectome. And in terms of the Omni, like I was talking about earlier, you can do viscodilation. So you put the Omni device into the angle and you kind of run it 180 degrees. And as you're pulling it out, you're placing visco into Schlemm's canal and vasodilating. And the good thing about that is for example, if those collector channels are blocked, this vasodilation is going to force that fluid to be able to go down newer paths. And then in some cases, if you like, you could actually, put the suture back in and then remove that trabecular meshwork. So Omni is a new device. It's a wonderful device along the lines of canal surgery that you can do as a standalone, as opposed to the hydrocin iStent that you have to do with cataract surgery. Canaloplasty has been around for a long time. Trabeculectomy has been around for a long time. This is actually the standard treatment for pediatric glaucoma, to do this canaloplasty and to try to open up trabecular meshwork. Here's a picture of just a standard trab. So there's a lot of different flaps that people use, but originally canaloplasty, we were doing it externally, but now with these new devices like the Omni, you can go inside the eye and dilate. So that is pretty much all I have for today. If there are any questions, and then my email address, if you have any interest in coming to work for Thomas Eye Group.
I do have a few questions here. We have to fill a little bit of time, but I have 3 questions here, and I'm sure Joe has a few questions. My first question would be, you just discussed these MIGs in primary open-angle glaucoma. When it comes to, I'm just going to pick 2 secondary, pigmentary glaucoma and pseudoexfoliation, does that change your treatment plan whenever, or is it still the same MIGS procedures when it comes to these secondary types of glaucomas?
So with secondary glaucoma, pseudoexfoliation, pigmentary glaucoma, I definitely like using the SLT. Those patients respond very well to laser treatment. In terms of if they're going in for cataract surgery, it depends on how advanced their disease is. So if they have mild glaucoma, I would lean more towards an iStent. If they have more moderate glaucoma, then I would think more of angle surgery or stenting with a hydrus or a cahook. I think usually for pseudoexfoliation, you have to be very careful with cataract surgery because those patients can get dislocation of their lens over time. And so it really takes a skilled surgeon because, the pupil goes down, there's a lot of complications when it comes to pseudoexfoliation. Pigmentary glaucoma has kind of 2 peaks. So there are younger myopic patients, traditionally male patients that develop that develop pigmentary glaucoma. In those patients, I would opt to do SLT. And then if I did have to do surgery, I would do goniotomy and just open up the angle, because a lot of that earlier glaucoma, treatment with goniotomy is actually helpful. So similar to like congenital glaucoma or juvenile glaucoma, those patients have a great response to cahook or Omni, anything that removes the trabecular meshwork or opens up the trabecular meshwork. The second group of pigmentary glaucoma patients are patients that develop it when they're older, and this is actually thought to be they were glaucoma suspects or pigmentary glaucoma suspects throughout their life. And what they're actually developing is primary open-angle glaucoma, but they also have these pigmentary changes that they've had their whole life. We just weren't treating them because they never had any damage to their nerve. And so the second group is developing primary open-angle glaucoma, even though they have pigmentary changes. So you treat them similar to a regular primary open-angle glaucoma patient. But I think the goal is just pressure reduction for any type of glaucoma variant in earlier surgery, because we know that 1/3 of patients don't use the medications we prescribe. So
right.
if we can move, to these mixed treatments earlier, and some of them work very well. And I think historically we were doing a lot of trabs. The problem is that the trabs for a lot of patients, you got a good 10 years. That's all you're going to get out of a trab, right? So if we're doing trabs on patients that are younger that we're diagnosing glaucoma, you're kind of setting them down a pathway of needing more surgery in the future. They're going to need multiple tubes. They're going to need other things because these traditional glaucoma surgeries were not built to last. And so we can do MIGS treatment earlier, then I would opt for that. If it was my own eye or my family member's eye, I would opt for a MIGS procedure first.
So with regarding these MIGs and becoming more popular, and I know a lot of them are done at the time of cataract surgery, and we have a lot of optometrists that are on the call here or on the webinar. And as these MIGs get approved to be able to do maybe after cataract surgery, how important is it to have that capsule? A lot of people go for YAG caps. You as a glaucoma surgeon, do we need that capsule? If they get a YAG cap, that posterior capsule, does that influence you going into opening that eye again and doing a MIG procedure? Is that okay to have a YAG cap?
It's perfectly fine.
Okay. And then the second question, or the third question I have is, I see some surgeons stopping a prostaglandin analog before an SLT. Thoughts on that and how we should advise, the patients before maybe coming to see you for an SLT?
So there's very good data that stopping the prostaglandin before SLT can lower the eye pressure. I think that you have to be careful, stopping any medication because patients can get pressure spikes. So I opt to only stop it if they're on monotherapy. So I will stop it about 2 weeks before I plan to do SLT, especially if they're having side effects. But in somebody who's on multiple medications, I would not suggest stopping a prostaglandin analog before doing the laser treatment. There's also good data that stopping them before doing angle surgery or trabeculectomy or tube surgery can lower the eye pressure. But I think a lot of that is when you have very high eye pressure and you do any type of procedure, the IOP reduction is going to be significantly more than if you were already treating these patients. There's a smaller window for them to drop. And so sometimes glaucoma specialists will take patients off medication in order to get that large drop in IOP. So, a lot of the studies show like a washout period before they start doing any procedures. And they found that when they do that washout procedure, the patients have a better response to MIGs and tubes and trabs.
Yeah, we try to do that as much in our practice as we can, and we do kind of see that kind of I guess better efficacy whenever we see that done. My last question would be, and then I'll quit dominating and I'll let Joe ask his questions, is we've seen the laser peripheral iridotomy position kind of change from that kind of 12 o'clock position, maybe down to that 3 or 9 o'clock position. Is that kind of taking off across those glaucoma surgeons that are doing that? I guess because the tear prism was deflecting the light. We thought that the lid would block it, but now the tear prism is kind of shining light up in there. And now we're moving over to that 3 and 9 position. Have you done that, or are we seeing a mass movement? I'm just doing that because there might be our colleagues out there wondering why and looking for that PI superiorly. Where is it? Oh, it's down here. Why did that happen? So.
Yeah, definitely less dysphotopsia, less diplopia when you're doing the laser at 3 and 9. So I standardly do that. I usually try and do it nasally because I find that when I get ready to do cataract surgery, we're talking about different trials, like the Eagle study shows that early cataract surgery can help patients who have angle closure glaucoma. And so I usually do it at 3 o'clock because if I'm going in temporally to do cataract surgery, I want that iris to be very dilated. And so sometimes you can cause damage to the iris when you're doing a PI. And so you don't want to have to deal with that when you're doing your cataract surgery. But yeah, most glaucoma specialists are doing it at 3 and 9. I think, this is kind of one of those things that comes up for discussion every couple of years. Same thing with SLT. Well, should we do 360 or 180? And so I think we find less side effects from that.
Joe, do you have any questions?
No, I thought it was a very, very comprehensive talk on what we're experiencing today in glaucoma in 2021 and coming to 2022. And I enjoyed it greatly. I'm sure our audience did as well. A lot of great information in there. So thank you very much, Anita. It was terrific.